waiting for, or the risk of sudden death in asymptomatic patients. You may identify patients that if you operate, actually the risk of endocarditis may increase. We don't know that. And the other thing is, you don't want to operate in patients who may not need an intervention during their own lifetimes. So it is quite finely balanced, and we really do need trials. What we have lots and lots of are studies, observational studies, which have looked at risk prediction in asymptomatic patients with moderate or severe disease. Now, on the left-hand side are all the echo parameters which have been associated with increased risk. And the fact that we have about 15 tells you that none of them are very good. The best studied test is exercise stress testing, and there is less data specifically on imaging stress tests. Now, this is just an example of the number of studies that have been done looking prospectively at exercise testing to predicting outcome. And I just want to highlight, because this is where I disagree with the guidelines, and I'm going to explain why. So if you have an exercise test can identify people at increased risk of developing symptoms or complications. But in this paper from DAS, it was published in 2005, the positive predictive value of a positive test was 57%, and it was much lower in the older patients. In our own study, which we published in European Heart Journal 2 years ago, the positive predictive value for exercise testing with a strict definition, that was breathlessness, below 80% of predicted exercise capacity was only 47%. And across the whole board, the positive predictive value was only 38%. And what that means is 2/3 of patients who developed symptoms on the exercise test did not develop spontaneous symptoms within 12 months. So although the negative predictive value is good, in that you can safely monitor these patients, it doesn't mean that all those who have a positive test benefit from surgery. I hope you follow that. I'm happy to take questions on the end. So we have several studies which have compared outcomes of aortic valve replacement early while patients are asymptomatic versus waiting for symptoms to develop. In our own institution, about 20% of patients are referred whilst asymptomatic. And I was speaking to Marek last night. I've never had a surgeon refuse to operate on an asymptomatic patient. They love it because they do really, really well. And it's a bread and butter operation for them. So, overall, there's a suggestion that patients do better. Probably the best of these studies is the current AS registry that was performed in Japan. And in this study, there were 291 patients who had early aortic valve replacement, and they had propensity matched scoring for those who waited till symptoms. And what you saw was a very dramatic reduction in a combined endpoint of cardiovascular death, myocardial infarction, and stroke and heart failure hospitalization. But we cannot rely on propensity matching because there are unmeasured confounders. And the most obvious one is the cardiologist looking at the patient across the table or at the end of the bed and saying, I'm going to send you for surgery and I'm not going to send you for surgery. And frailty is almost certainly one of the commonest reasons why we wouldn't do it. And other things such as renal impairment are not measured. So now to the really interesting bit. Bernard has already shown you this. This is the extensive list of randomized controlled trials of asymptomatic severe aortic stenosis. There are none. And the guidelines reflect this in that the evidence, the class of evidence for intervention in asymptomatic aortic stenosis is C all the way through. So this really is, I mean, it's hard to say whether they really should be a guideline rather than a recommendation because we don't have the evidence to support it. So, as I mentioned, I'm interested in cardiac MRI as well as other advanced techniques. And the question that I've been asking, as have others, is can we improve risk stratification with more advanced techniques? Well, we need to think a little bit about what the optimal characteristics of a test are for identifying patients with severe asymptomatic aortic stenosis. The first thing is the test should be easy, ideally inexpensive to measure, readily available and reproducible. That goes without saying. It should reflect the disease severity. And ideally, in this condition, you want it to precede symptom development, but be closely related to it. And as I've pointed out, LV remodeling seems to be very important. So you want something that reflects that as well. You want high accuracy, or at least high specificity, so you know the patients who are not at risk. Now, this is something, again, in the literature that I don't really agree with. A good biomarker in this condition should identify patients who have excellent outcome following intervention. Whereas almost all of our biomarkers, and particularly if you look at natriuretic peptides, for example, what they do is they identify patients who are at increased risk of dying following surgery. We don't want that. We want patients who have excellent outcome when you identify the biomarker. And we need to bear that in mind. So some of the things that have come in recently are potentially the use of high-sensitive troponin. This work was led by Edinburgh and Mark Dweck. And what they did was created a clinical risk score in their patients with asymptomatic disease and stratified them into 3 groups. And this closely correlates with the presence of fibrosis on cardiac MRI. They've externally validated the risk score, but the same thing here is that AVR was not protective in these patients. I did a study where we looked at myocardial perfusion reserve because we all know patients get angina, they have reduced blood supply. We showed it was inversely related to symptoms in patients having aortic valve replacement, and it was the only independent predictor of exercise capacity. We tested it prospectively against exercise testing in the PRIMID study, 174 patients in a multi-center study, and myocardial perfusion reserve did predict outcome, but with really very modest accuracy. And the graph on the right, it was the accuracy for exercise testing. So both of these were associated with symptom development, but neither of them were very good. What we've also shown, and this paper's under review, is that if you leave asymptomatic patients for 12 months, they get really quite marked worsening of adverse left ventricular remodeling, an increase in volume, reduced ejection fraction, increase in fibrosis, even out to 12 months. So leaving these patients does not seem to be a good thing. With colleagues in the British Society of Cardiac MRI, we've undertaken a multi-center observational study of patients having research MRIs prior to aortic valve replacement or to TAVI. And what we showed is those who had evidence of fibrosis on late gadolinium enhancement had increased overall mortality here on the left-hand side, and increased cardiovascular mortality, and this was in 694 patients. So, moving on to the most important bit of the talk, we do have a number of randomized controlled trials in severe asymptomatic aortic stenosis. The first one I'm going to mention is one I'm involved with. It's led by Edinburgh again. It's been taking part in the United Kingdom, and it's really a stratified medicine trial. Patients with severe AS are screened if they have strain on their ECG or a troponin, high sensitive troponin above 6. They have a cardiac MRI. If the MRI shows any evidence of fibrosis, they are then randomized to intervention with surgery or TAVI or standard of care. Mark Dweck has just texted me this morning to tell me that they've now randomized 144 patients, and that's in about Edinburgh started 20 months ago, but most of the other centres have started in the last 14 months. And there is an adaptive design. The primary outcome has changed slightly from cardiovascular mortality and heart failure hospitalisation to cardiovascular hospitalisation related to AS. So it's a little bit softer. Marco's leading the AVATAR trial, which is taking place in 15 centres in 10 European countries. And this is the first trial to get underway. He tells me there's 132 patients randomised. It was very difficult to recruit because coronary angiography was mandated in all patients, which is not routine practice. That's now been dropped, and I hope that they manage to go on and complete the recruitment. Many of you will know there's also a large trial planned of early TAVI In North America, the planned sample size is 1,109, and there's a major adverse cardiovascular endpoint of death, stroke, and unplanned cardiovascular hospitalization. I'm uncertain how many patients have been randomized, but this will be limited. It's degenerative disease, patients over 65, and with one manufacturer's device. And finally, we have recently secured funding to undertake a very large, pragmatic, randomized controlled trial. At the third time of asking, the British Heart Foundation have agreed to fund this, and the study has also now been funded in Australia, and we're calling it the EASY AS trial. And it really is severe AS, yes or no, surgery, yes or no. And BHF were adamantly wanted an efficacy endpoint, not a combined efficacy and safety. So our primary endpoint has changed to cardiovascular mortality and heart failure hospitalization. The plan is to recruit up to 2,844 patients, and it is planned to have a relative risk reduction largely based on the current AS registry of only 25%, unlike Evolved, which has a 50% relative risk reduction planned. And I think if we can do this, we have to randomize 200 patients in the first year. And if we do that, we'll roll it out to 100 centres in the United Kingdom, 20 centres in Australia, and there are bids currently in both Canada and New Zealand to fund this trial. So to finish, in the absence of randomized trials, we have to base our current decision making on individual risk-benefit assessment. And this is a paragraph from the 2012 European guidelines, which I think is really useful. The decision to intervene in a patient with valvular disease relies on an individual risk-benefit analysis suggesting improvement of prognosis as compared with natural history, outweighs the risk of intervention and its potential late consequences, particularly prosthesis-related complications. And that's what we have to bear in mind in clinic. So, currently, AS management in asymptomatic disease is controversial. Its decisions should be individualized. Surgery, I think, is reasonable in asymptomatic patients, but it's supported by low level of evidence. And if we really want to prove that surgery or TAVI is beneficial, we need to do the trials. So I personally don't think exercise testing should have a class 1 level of evidence. We're waiting for TAVI trials to give evidence in asymptomatic AS, and these randomized controlled trials will give us the evidence base to base our future management. Thank you.
Thank you very much, Dr. McCain. We have time for one question. This was a very good lecture. I would also would like to ask you, is there any place for Holter ECG in following up patients with aortic stenosis? Because we know that some of those patients might have a sudden cardiac death.
Yeah, so it's an excellent question, and we're not quite sure what the mechanism of the sudden cardiac death is. If you believe that the mechanism is similar to syncope, then probably the mechanism is left ventricular baroreceptor activation with reflex bradycardia. But I don't know that for certain, and I think it's an area that's worth studying. And of course, the other thing that we need to remember is the risk of sudden death is not abolished by intervention. And actually, I think, recurrent sudden deaths and heart failure hospitalizations are areas that we need to think about going forward. And the surgeons always say we refer patients too late. Sometimes we just don't see the patient until they present with heart failure or severe symptoms. Okay. But thank you.
Thank you very much. Once again, we are moving to the next lecture. Dr. Banovic, TAVI trials.